guys, welcome to week 14, which is the actual last week of presented material that you'll see on your final. So next week is just a case study to talk about a specific medication and just to kind of tie up the last of the semester. So this week we're talking about pharmacogenetics. So we need to understand that all drugs are prescribed for all patients because we want to induce a specific patient response. And we expect when we prescribe them or administer them that there'll be a change in function in either the tissue, organs, cells, and that can either be multiple or it can be a single. And this intended action or therapeutic effect is what we prescribe drugs for at the doses and at the time intervals that we do. We're trying to achieve a therapeutic effect or an intended action. So some terms we need to be familiar with is we need to understand that pharmacogenetics that talks about the effect of a single variation. So that's one variation, one single gene variation on that drug response that we get from taking medication. And then there's the term pharmacogenomics, which we're looking at the whole genome for these variations in drug responses. So keep those two definitions in mind as you study for the final and as you think about this week's quiz. And we want to know how drugs respond within our body. We know are based on coding within our genes. And those codings have a relationship and are related to metabolism of those medications, the transporters required to carry that medication to the designated tissue or organ, and the receptors that may or may not be needed to initiate that drug response. We also need to look at and review the term pharmacodynamics, which is, as you all learned, is the body's response to a drug that is introduced. The response to the drug can either be intended, which is what we're trying to achieve, or it can be adverse and the patient can develop side effects, and these can be minimal to life-threatening. Drug working by changing or altering the activity levels at the cellular level. So they have a mechanism of action, and we need to remember some drugs do require receptors to carry out this mechanism of action. And then there's pharmacokinetics. This is the body's actions that change the drug either physically or chemically, and then this is the changes that go on in the body, how the body changes the drug. So we have to remember that drugs are foreign substances that are introduced to the body, and the body's goal when there's a drug introduced is to prepare it for elimination. And there are three main components of pharmacokinetics, and that's absorption, metabolism, and elimination. And there's a good figure on your book, 15.4, which kind of shows a little bit how if someone might be a slow metabolizer, a rapid metabolizer, how that might affect how the drugs are eliminated, and therefore alters the therapeutic or intended effect of that drug, which can require alterations in dosing frequency, and also monitoring for blood levels or adverse blood levels, such as if we take a drug that has a risk of kidney damage and we know that someone is perhaps a slow metabolizer, we know they aren't going to eliminate it at the same rate, so we might want to watch those liver studies more frequently than someone who, the average person with normal response to those things. So we need to talk briefly about adverse drug reactions, kind of one of the biggest hot topics right now in medicine. We know that on average, hospitals have a 6.7% adverse drug reaction rate. we know that 0.3% of those can be fatal. And the large majority of those are genetically determined. But we don't have the information at our hands right now to determine which patient would have those kind of genetic adverse reactions. Um, and adverse reactions, we know that we metabolize drugs through liver enzymes for reaction, and we know that we excrete through the kinases. And so that particular process is also determined by our genes. And if those are altered in any way, we are as an individual, at a higher incidence of having an adverse drug reaction. So we know that our ability to metabolize and excrete, this requires biochemical reactions, and this is involved in metabolism of even ordinary food, substances, as well as drugs. So research believes that there are mutations um, that arise to the dietary selective pressures in different populations, which increases someone's risk for perhaps a food allergy or a drug allergy. And this research is supported by the geographic distribution that have been able to be located on some of the alleles when analyzing DNA, chromosomes, and the genome. So we need to understand that when we look at potency, or you see potency in the literature, what that actually means. So when a drug company develops or says it's potency, that's really defined as the dose it takes to produce the therapeutic effect in approximately 50% of adults weighing 150 pounds. So as you can see, we have a significant rise in obesity in America, and 150 pounds may not be the average weight of an adult. So drug companies may need to rethink that so that we hit a better population and are more accurate in determining the potency of medications. So we're going to run through a few pharmacogenetic diseases. I will tell you, you will see some questions about these on the final. So the information you have either here or in your textbook should be able to allow you to answer those questions. Okay, these are the 5 diseases we're going to talk about: malignant hypertension, BCHE, patients who are slow acetylators, acute intermittent porphyria, and response to Coumadin, and what's called the G6PD Deficiency. So we'll start with malignant hypertension. This is what is termed as an operating nightmare. It's an autosomal dominant trait, and there's a mutation on a gene which is called RYR1, and that gene is located on chromosome 19, and its responsibility is the calcium ion release from channels. They've also located some other places where there could be a mutation, and this also includes for the alpha 1 subunit. So they're being able to look at what people who develop malignant hypertension have in common in order to be able to determine which people will be at risk for developing this. So what happens is that there's a dramatic adverse response to the administration of a combination of drugs used to induce anesthesia in the operating room. This combination includes inhalants used to induce sleeping. One in particular that they found is halothane, and also the use of muscle relaxants, one in particular succinylcholine. So generally when you have a patient with malignant hypertension, there's a sudden onset of a very high fever. The patient develops sustained muscle contraction, often to the point that he cannot breathe on his own. The patient is in a state of hypercatabolism, And if it's not rectified, it can actually lead to death in the operating room. Below, I've given you the incidence. So, males outnumber females in whether or not they will develop malignant hypertension. And they wonder if part of it might be related to hormones, so they're still looking into that. But the main pathway is due to that there's an elevation in ionized calcium in the sarcoplasm of our muscle. So this leads to increased muscle rigidity, the fever, and the other abnormalities that you see. So this gene we talked about, the RYR1 on chromosome 19, um, in linkage studies that we talked about in another week, show that this mutation accounts for approximately 50% of the cases. They are looking at other gene mutations, which may account for the other 50%. So, dantrolene sodium can be used in preventing or reducing the severity of the development of malignant hypertension. And patients are who have either experienced it at one time or have the defined genetic abnormality on genetic testing may be given alternate anesthetic choices. So once a person has malignant hypertension, they will not receive halothane or succinylcholine either individually or together in the future. So that would be listed as an allergy. And when we fill out their anesthesia history, sometimes on admission, this would be something we would want to note. Um, and that we would encourage that person to be genetically tested prior to any additional surgeries. But if people were routinely genetically tested to see pharmacogenetically tested, perhaps we would know those that would be at risk, and then they would not receive this combination of anesthesia or receive either one of these drugs. We do use succinylcholine when we intubate people, so they would not be given these medications individually, so therefore they would be at no risk for developing malignant hypertension. So BCHE has to do with acetylcholine. So we know that acetylcholine is a neurotransmitter for much of our sympathetic nervous system. It helps with our respiratory system, and serum cholinesterase breaks it down. So again, the muscle relaxant succinylcholine is often used as an adjunct for general anesthesia. It helps with intubation and when we cut through muscles because there's muscle paralysis. That happens with the use of that medication. So what happens is succinylcholine is normally hydrolyzed by this cholinesterase, but people who have a genetic mutation do not hydrolyze the succinylcholine normally. They have found that people with European descent or population um, genetically do not have the gene needed to make this cholinesterase. And they've done that on linkage studies and looking at populations that have things in common. So what happens is that they don't break down succinylcholine at a normal rate. So what happens with these people is they may remain on artificial ventilation for several hours, perhaps to days, after the operation is over, because it's going to take longer for that succinylcholine to pass out of the body through the kidneys. They're finding through research that this BCHE chromosome is on chromosome 3, and when you have the mutation, you have what's known as a missense mutation. So we look at rapid or slow acetylators, and how this came about is when TB patients were treated with ionization, it was noticed that some of them got toxic and they developed neuropathologies as well as liver problems more quickly. And so they looked at studying these individuals and to look at whether they were rapid or slow acetylators were discovered. So what happens is that there's an acetyltransferase gene that's located on chromosome 8. And this Na2, and later they discovered this Na1 was found on these people. So what happens is in the normal healthy person, this gene that they located allows for rapid acetylation and normal metabolism of drugs. So therefore drug levels get to a therapeutic range and they don't develop toxicity. So as you can see, the patient who would either be rapid or slow, how that might affect the metabolism and toxicity of these drugs. We know that the mutated gene they have found is recessive, so it takes having both um, inherited both mutations um, to develop rapid or slow acetylation. And if patients have this mutation, they metabolize their medications much slower, and therefore they're at greater risk for developing toxicity, adverse reactions, or side effects. So, slow acetylator toxicities, one specifically we just talked about was a isozanide that is used for TB. There's another drug used for leprosy, hydralazine, which is a med used for hypertension. And when patients are toxic on hydralazine, they can develop a lupus, systemic lupus-like syndrome. We know that this can happen with some sulfonamide antibiotics, and that these antibiotics can give the patients blood dyscrasias. So, knowing whether a patient is a rapid acetylator or a slow acetylator can help us. So, you can develop toxicities. So, sometimes patients can have an increased incidence of bladder cancer if they're exposed to carcinogenic benzidine, because it's going to be they're going to have it in their urine longer. And we've known that some postmenopausal smoker women can have increased risks of breast cancer. So with slow acetylators, they're going to develop toxic effects, and they can develop some pretty significant toxic effects. So let's talk about how that might apply to our clinical practice before we get off this slide and move to the next one. So if someone is a known slow acetylator, that means that we need to know, that tells us how they metabolize the drug. So if they're at higher risk for toxicity from that drug, we either as healthcare team members need to advocate for perhaps the use of a different drug, closer monitoring for side effects, or decreased dose and perhaps decreased spacing in the time that the patient could get that medication. On the flip side of that, if we know that someone is a rapid acetylator, that means they metabolize the drug very fast. They may actually take more of the drug needed in order to reach the therapeutic effect that we're looking for. This might be the patient, and we're going to talk about Coumadin later, who metabolizes Coumadin very rapidly. That patient is going to need a higher dose of Coumadin, and we wonder why their INR isn't coming to the therapeutic range we'd like it to be. Perhaps they're metabolizing that drug much faster than that, average 150-pound patient. So we're going to talk about acute intermittent porphyria. This is an autosomal dominant disease, and it causes intermittent neurological dysfunction. So the patients and many clinical episodes are started by medications. Some of those medications might include steroids, barbiturates, and other medications that affect the hematic cytochromes P450. So you've all heard about the P450 in terms of drug metabolism, and in your discussion, the person who talks about drug metabolism from our book will go into this a little bit more, but for your information, it's always really good to understand the P450 system. So also starvation can set off the syndrome. So the syndrome results from unaltered regulation of genes that control the synthesis of heme and leads to this pathophysiology. Often patients don't show any signs of the disease until they're exposed to a medication that sets off the symptoms. So, like I said, in pharmacology, you learned about medications that can affect the P450 system. Um, if patients have alterations in the P450 syndrome, they need reduced doses or not take the medication at all, and that depends on how it affects them. When patients are exposed to more than one hepatic cytochromic P450 that works through that system to metabolize it, it can stimulate an increase in red cell production. And that's what causes this porphyria, is that they have this increased in RBCs. So this can cause an increase in pulse and blood pressure. And for patients who have heart problems to start with, this can increase those dramatically. Also, patients may experience abdominal pain from congestion around the spleen and stuff from this increase in red blood cells. Some patients have been known to have psychotic events, and this is related to an increase in intracranial pressure. So, other central nervous system side effects you might see might be peripheral neuropathies are unknown. The treatment for this to decrease these symptoms is to stop taking the medication. By no longer taking the medication, the syndrome is said to have ended. So one thing we also need to understand is Coumadin metabolism. Coumadin or warfarin is also one of those drugs that's metabolized by the 450 enzyme system. So there have been two genes that have been found that have mutations that can affect the metabolism of Coumadin. So now we can test people to see if they have these genes, and therefore we can put them on a dosing protocol as a result of these genetic results, and it will help us achieve those therapeutic INRs faster with less risk of bleeding. So we also have the G6PD deficiency. This is a deficiency in glucose 6-phosphate dehydrogenase. This is an X-linked enzyme, and it's the most common disease-producing enzyme defect in humans. So it is estimated through research that approximately 400 million people in the world have a G6PD deficiency. Um, so for Americans and African American males, the most affected group. So when we have this deficiency and we get exposed to a medication that affects the G6PD system, it causes breakdown of red blood cells. So one medications that do this are sulfonamide antibiotics, um, a drug called dap, dapazone, which is used for leprosy, and there are sulfons, which are also used for pneumocystis coccinea, which is a type of pneumonia that is mainly seen in AIDS patients, and also from this chemical that's used in making mothballs that people put in their closet, which is why they're toxic, and there are other medications. But the chemical is also found in faba beans. So, so a high prevalence of this disease is due to the fact that heterozygotes have some resistance to malaria. This is especially true for have developed a resistance to malaria. So we see this in Mediterranean areas and the African continent. When the medication that causes the problem is stopped, the anemia will eventually end. The body will have an opportunity. There will be nothing in there causing the breakdown of the red blood cells, so the body will be able to regenerate red blood cells that will then not be broken down. So then briefly we'll talk about adverse reactions. Thiopurine drugs which are used to treat some leukemias and autoimmune diseases like lupus and prevent transplant reactions. 10 to 15% of patients who receive these types of drugs will have a severe toxic reaction to the meds. There is a gene called the TPMP gene, which is responsible for this toxic reaction. So it is recommended, it is hopeful that someday before these drugs are administered, that people will be tested to see if how they will react before the drug is administered. We can see 5-FU toxicities. So 5-FU is used to treat many cancers. Those of you who've been in oncology before have heard of 5-FU. So people lack an enzyme that can't catabolize the chemotherapy drug properly and they get toxic. So genetic testing is available should people want it to ID people who we should not be giving 5-FU to because they have a deletion exon, which allows them to not catabolize this particular medication. MODY, this is a thing that is called maturity onset diabetes of the young, and these are people who are about 25 years of old when they get their diabetes. This is a dominant trait, and this causes them to lose their beta cell function as a result of a mutation in a couple genes. And people with this are sensitive to sulfonylureas, and these patients should be treated with a lower dose of sulfonylureas, otherwise they will have an increased risks of hypoglycemia. Neonatal diabetes, they found a couple genes that cause a dysfunction in the KATP channels within the pancreatic beta cells. So these channels don't close properly and don't allow insulin to be secreted. So understanding this etiology can lead to treatment with sulfonylurea drugs because these help cause the channels to work, and this can trigger insulin secretion. So pharmacogenomics, looking at the whole genome and how people respond. In the near future, researchers are hoping that everyone will be able to have their genes tested at a reasonable rate in order to understand their medication sensitivity profile. So this will allow us to know what medications they will have adverse reactions to, or even more likely to have adverse reactions. So they will not receive these drugs at all if there's a better alternative to treat the issue that's going on with this patient. It will also help us know what medications work best for that individual. It will allow us to know if they're rapid metabolizers or slow metabolizers, and therefore we can adjust dosing and frequency for those patients to both achieve therapeutic and intended effect, or to prevent adverse reactions and life-threatening complications. There are newer and safer drugs that can be developed that could fit a specific genetic profile. And genetic profile chips, although at this time can be expensive, the thought is that if we look at the cost benefit savings, that people who know their genetic profile will actually, in the overall scheme of picture of medical treatment, will actually end up saving them money because they won't be given drugs that are not effective for their own particular genetic profile. There'll be less cost in treating adverse reactions. There'll be less costs occurred from lawsuits that are prevalent from adverse reactions to medications. So patients will not have to do so much trial and error to find the medication that works for them or the dosing that works for them. So perhaps that could cut down on office visits as we're trying to regulate patients' medications and switching them because we're having difficulty finding one that works for that patient. So in the big picture, perhaps it will decrease also costs of medications because pharmaceutical companies maybe not have to carry as much insurance, and so insurance costs will go down, which hopefully then will reflect in the cost to the consumer. So perhaps in the big picture, it could affect cost overall, and therefore we would be saving money and we'd be able to provide a better and healthier medication management for patients. Thank you for your time.